My name is Elias Jabbour, and today I'll be discussing and commenting on the Bleximenib dose optimization and determination of recommended phase 2 dose from a phase 1 study in refractory acute leukemia with KMT2A or NPM1 alteration. So what we know so far that these patients with refractory acute leukemia have very poor outcome with high unmet need for novel therapies. We know as well that Bleximenib is a potent selective inhibitor of the menin KMT2A complex, and the activity has already been observed in these patients when given either as a monotherapy or in combination in a frontline refractory disease as well. We've already shown the data last year at ASH, and then we've shown at EHA as well the data on a combination. Therefore, the focus of presentation at ASH is to review the data that inform the Bleximenib recommended phase 2 dose from ongoing phase 1 multi-center dose-finding study of Bleximenib monotherapy for KMT2A rearranged or NPM1 altered refractory relapsed acute leukemia. So the study started a couple of years ago, and it's a phase 1 study. Therefore, there was a dose escalation, and that was guided by pharmacokinetics, pharmacodynamics, and responses observed, as well as safety. We start escalating, and then we start testing several levels at 45 milligram BIDs. Then we went to 50 milligram for 2 weeks BID, then 100 milligram BID. Then we went even higher in a dose to 50, followed by 150 milligram BIDs. We treated 146 patients were dosed. And of course, these patients were KMT2A and NPM1 altered, and even we treated somebody patient with NUP98-14 altered leukemias. Based on this is the design of the study, and the idea was to determine the recommended phase 2 dose, and based on the observation we had, safety, efficacy, PKs, and others. The recommended phase 2 dose was Bleximenib 100 milligram BID orally, which with a 50 milligram BID step up dosing for 2 weeks. And this is the dose recommended for the phase 2. As I said, 146 patients were dosed, and the characteristics are typical for refractory acute leukemia. The majority were AML. Median age was 60 up to 85 treated, and 57% were KMT2A rearranged disease, 40% were NPM1, and 3.5% were NUP98 or NUP214. Patients were pre-treated. Median number of therapy was 2. And then a quarter had already received 1 transplant or more. Around 80% were performed at 0 or 1. Again, we had 3 dose schedule. When I focus on them here, the 45 milligram BID were 15 patients treated. 40% came to rearranged disease. Bleximenib 100 milligram BID, 31 patients. Half of them came to rearranged disease. And 150 milligram BID was 33 patients, and half of them were as well KMT2A rearranged acute leukemias. Adverse events observed, regardless of therapy, usually treatment was well tolerated. The most common adverse events include cytopenias and GI disturbance. Grade 3 and more most common treatment emergent adverse events were cytopenias. Of interest, we have not seen QT prolongation, which is quite reassuring. And differentiation syndrome was observed in 14% of the patients across all those levels. Then if we want to focus on something related and what you've seen adverse events, the safety profile optimized with Bleximenib 100 milligram BID was the best seen. In fact, discontinuation rate at this dose level was 6.5 milligram per day. And we've seen more discontinuation and dose modification at the higher dose at the 150 milligram BID due to adverse events. And we've seen as well more neutropenias. And as such, when we've seen more toxicities at the higher dose, 150 BID wasn't therefore the best dose schedule to be considered, and therefore the 100 milligram was more optimal. How about differentiation syndrome observed in our study? We know it's a class effect for all menin inhibitors. All grades in 146 patients, we've seen 14.4% all grade. Grade 3 and more were 6.8%, and that was seen as well at the recommended phase 2 dose of 100 milligram BID, which is 19.4% all grade, 6.5% grade 3 and more. The DS was observed similarly across KMT2A and NPM1. I would like to say mostly were low grade. 2 fatal cases were observed in all those patients. Mitigation measures were implemented, and that consists into temporarily interrupting the Bleximenib with initiating hemodynamic monitoring. Steroid was administered, hydroxyurea as well, supportive care, And we only resume Bleximenib when the signs and symptoms resolve to grade 1 or less. Just to highlight that the median time to onset was 8 days. Some patients experienced recurrent DS. Most initial cases of DS occurred in cycle 1, and the most common signs and symptoms were leukocytosis, increased ferritin, dyspnea, hypotension, increased body weight, and bone pain. So therefore, based on the safety and efficacy, we selected the 100 milligram BID as our recommended phase 2 dose. And here I'd like to focus on the efficacy population. On an intent to treat efficacy population, we're defined by refractory AML having 5% of blast and more with either KMT2A disease or NPM1 mutation. Patient must have received Bleximenib at a dose level up at 45 milligram BID or higher. These were the patients selected for the efficacy population. Patients who discontinued therapy even before first evaluation were evaluated as well on an intent to treat basis. So let's focus therefore on the efficacy set of patients, which is 56. When we look at the objective response rate overall, it was 36.4% at the 45 milligram BID, 47% at 100 milligram BID, and 55% at the higher dose, which is 150 milligram BID. But let's focus here at the dose used for the recommended phase 2 dose was this composite CR, CRh, CRI was 38%. CR/CRh was 33%, time to response was 1.4 months, and a good number of patients, 14.3%, received transplantation. The follow-up, the mean follow-up is 6.5 months, and duration of response was 6 months. Overall, 12 patients proceeded to transplantation. Now then, let's focus on the group who received the 100 milligram BID. Again, we look at the KMT2A disease or NPM1. We've seen the drug being equally effective in both a subset, with the composite CR being 44% for KMT2A disease and 33% for the NPM1. And for CR/CRh was equally 33.3% for both. Subsequently, we look at the pharmacodynamics and look at the correlation between responses and what's happening here. What we've seen, dose-dependent reduction of the menin KMT2A target gene expression, MEIS1 observed, and that was consistent with the mechanism of action of the drug. At Bleximenib dose of 100 milligram BID dose level, significantly greater inhibition of MEIS1 after first treatment cycle compared to 45 milligram BID dose level, and similar inhibition to 150 milligram twice daily. Therefore, the data indicate optimal target engagement rapidly achieved at 100 milligram BID dose level. So I show you safety, I show you efficacy, and I'll show you the pharmacodynamics. And therefore, in conclusion, this phase 1 data informed a Bleximenib phase 2 dose of 100 milligram BID with a 50 milligram BID step-up dose for 14 days as monotherapy in refractory AML with KMT2A or NPM1 mutated disease. Bleximenib 150 BID was associated with more adverse events, leading to more discontinuation and modification and increased grade 3 neutropenias without any clear benefit in efficacy or pharmacodynamic activity. At the optimized dose of 100 milligram BID, the CR/CRh rate was 33% for the treatment as a monotherapy, and the treatment was well tolerated with a manageable safety profile. We have seen no cardiac safety signal identified, and while the DS was emerging as a class side effect, we have successful strategy to mitigate this differentiation syndrome. So therefore, the phase 2 portion of the study will further evaluate Bleximenib monotherapy at 100 milligram BID in refractory AML with KMT2A disease and NPM1, and the study is ongoing.